cancer surgeon, and we may have a few minutes at the end of her talk for a few questions or discussion.
Good morning, and thank you. It's a pleasure to be here. I was asked to answer the question, should we image the CLI patient or go directly to angiography? And this turned out to be a relatively difficult question to answer. I'll do my best to sort of go through my thinking. These are my disclosures. I figure it's best to just start with a case. This is a patient, I'm sure we've all seen similar ones, 62-year-old, relatively young patient from my practice, diabetes, hypertension, hyperlipidemia, had a prior kidney transplant. He presented after a failed partial foot amputation, which, as you can see in the picture, had fairly significant amount of ischemia as well as some infection. Duplex showed monophasic flow from the distal superficial femoral artery all the way to the ankle with an ABI of 0.7, and he did have vein mapping with adequate vein. So this is a patient with essentially a Wi-Fi stage 4 wound. He got an x-ray to evaluate his foot, and he had this finding, which I find always concerning, and so often the case with these patients with diabetic ulcers as well as in end-stage renal disease with the calcified tibial vessels. And when I see this, I essentially go straight to DSA, which is what I did on this patient, and here's what I found. Fairly significant calcified SFA disease with a chronic total occlusion in the distal SFA, reconstitution of the popliteal artery with one vessel runoff through the PT. Patient is 60, has a good vein, has a pretty significant disease with one vessel runoff. I took him for a fem-pop bypass, and he ultimately healed the guillotine given the extensive nature of his wound. The question, of course, is could some other sort of cross-sectional imaging had made an impact on this patient? I didn't do that with this patient, but can it make a difference? CLI-specific considerations that we all have already talked about and know. Patients have often multifocal disease, often calcified disease, and so often below the knee, where the vessels are not only small, but also calcified. I don't think anyone would argue that adequate imaging of the vascular anatomy is particularly important, but not always that easy. And we have some options, duplex, of course, and then some cross-sectional imaging. So let's start with what the experts say. We've heard that following guidelines is helpful, so let's look at the guidelines. This is one guidelines, the ESVS Guidelines, specifically looking at recommendations for imaging patients with lower extremity artery disease, and here's what they recommend. Duplex ultrasound, and or CTA, and or MRI. I'm not sure that helped that much. The global guidelines that we've been hearing about also recommend to obtain high-quality angiographic imaging of the ankle and the foot, and then they go through a flow diagram to suggest ways to obtain that imaging, starting, of course, with a duplex, then recommending a CTA, although for significant infrapopliteal disease, this may not be recommended. The other option is an MRI. Again, if there's inadequate imaging, you can go to a DSA. And of course, there's also still the option of going straight from the duplex to the DSA without really much clarity of when and with who do we go one way or the other. So I was left still questioning how to answer this question for you guys today. So let's look a little bit about what the potential benefits of these cross-sectional imaging are. CT angiography, it's non-invasive, excellent patient acceptance, it's rapid, and we have the ability to evaluate previous revascularizations, I think particularly helpful. The cons, of course, there's image interference with calcified vessels, there's nephrotoxic exposure, radiation exposure, it's potentially less reliable for infrapopliteal vessels, and it can be costly. This is a modern study, and there's been several meta-analyses of CTAs for the evaluation of patients with peripheral vascular disease with fairly good sensitivity and specificity. This is a more modern study with high-level, sort of sophisticated CT scans, and they show a high level of sensitivity and specificity. However, they do mention that in the infrapopliteal segment, that specificity in particular decreases significantly, and is even worse in the presence of significant calcification. What about MR angiogram? Also non-invasive, less radiation, unaffected by arterial calcifications, but this can be time-consuming, costly. There's obviously patients who are contraindicated, and there is a tendency to overestimate the stenosis. This is an interesting study comparing patients with critical limb ischemia who had MRA to their DSA. They found a very high level of sensitivity and specificity with this imaging, and they found this interesting fact that there was a group of patients, about 7 of them, that had infrageniculate vessels that were identified actually on MRA, but not on DSA. potentially due to the timing of the DSA, suggesting maybe that this could be helpful. They could help us find some unfound vessels for a bypass or a revascularization strategy. But this paper just looked at imaging and didn't talk about the potential outcomes. So let's go back to my patient again, the 62-year-old gentleman, Wi-Fi stage 4. I did the diagnostic DSA and a successful FemPop bypass. Again, let's ask the question, could pre-DSA cross-sectional imaging have made an impact? What could it have done? Perhaps helped my preoperative planning, evaluated disease severity, been a non-invasive way of making the same decision, helped me to identify bypass targets, and help with the conversation with the patients. What about some other outcomes? Could it result in a quicker care for the patient or quicker procedure if I did go endovascular, potentially less contrast or less radiation? I tried to dive into this a little bit. There's not a lot of data here. This is a study out of our group, actually, that looked at patients who underwent ultimately endovascular revascularization and had cross-sectional imaging with CTA beforehand. And what they found was this. Patients with 100% vessel calcification, so chronic total occlusions, but with 100% vessel calcifications, had a 10x decreased chance of successful crossing of that CTO, suggesting maybe that this could be a little bit of help. The group then decided to look a little bit, more at this. Could pre-procedural cross-sectional imaging impact our percutaneous or endovascular strategies? So this is what we looked at. We looked at patients who had first-time endovascular interventions at our institution over a period of time, and just essentially looked at whether they had cross-sectional imaging prior to their intervention or not, and it was roughly 54% to 46%. Patients who had just diagnostic imagings and no attempt at crossing or revascularization were excluded from the evaluation. This is just the variability in terms of the obtainment of procedural cross-sectional imaging by surgeon. You can say there's a fairly significant amount of variability between surgeons, between 30 to 62%. However, it's really not an accurate evaluation because the majority, at least for this group of patients, or our group, the majority of cross-sectional imaging actually happened prior to the transfer of care in an outside hospital. These are our patient demographics, as you can see here. They were really pretty similar, except for, as not surprisingly, there was a higher level of chronic kidney disease in patients without pre-procedural cross-sectional imaging. Indications also didn't differ. Their indications being claudication or rest pain or wounds were no different between patients who received pre-procedural cross-sectional imaging, but the disease distribution did differ, as you would expect. Aortoiliac or common femoral disease was more commonly pre-procedurally imaged, as was patients with SFA and POP occlusions. So here's the outcomes. There was really no significant difference in procedure time, radiation exposure, contrast volume, anything between patients who had cross-sectional imaging versus not. What about the successfulness of the revascularization? We also didn't see a significant difference in terms of success rate. Patients with cross-sectional imaging had a 91% success rate and 86% success rate in terms of revascularization for those without cross-sectional imaging. However, there was one particular subgroup, again suggested by that prior paper. There was 89 patients who had complete FemPop occlusions, and those patients actually had a statistically significant increased rate of technical success if they had pre-procedural cross-sectional imaging. And also we found that patients had a higher number of diagnostic angiograms if they had no pre-procedural cross-sectional imaging. So in conclusion, I don't have a lot of data here. I haven't been able to support this question very well. Should we image the CLI patient or go directly to angiography? I believe it still depends. I don't think there's very clear impact on outcomes except for potentially this subgroup of patients with SFA and POP CTOs. So I'll just conclude with my algorithm. I do not get pre-procedural cross-sectional imaging if patients have no signs of inflow or common femoral disease or significant FemPop disease. I particularly avoid it in patients like my patient with x-rays showing significantly calcified tibial vessels. And if there's significant tissue loss and fall into those global guidelines for an open bypass and they have a good vein, just go right to it. I do get pre-procedural cross-sectional imaging, however, in patients with common femoral disease or inflow disease, FemPop occlusions, or significant prior interventions. And that's it. Thank you.
We have a couple minutes for discussion, and I don't